Hi, everybody. We're going to talk about sleep today. Sleep, I believe, is in chapter 43. We all love sleep, and I'm actually thinking about sleep really hard right now. Um, but sleep is really important to our physical and emotional health. As you probably can tell from college and other times in your life, that we really, are if you think about your physical and emotional health can really be dependent by how much sleep and rest that you get. And without it, if we think about our patients, their ability to concentrate, make judgments, promote healing, and participate in daily activity really decreases. So when we think about our patients in the hospital and yet alone ourselves, how sleep can really affect us. So when we think about our patients in the hospital, while we're caring for our patients, we really have to think about their individualized approach to sleep and rest. Might depend on a lot of different things, and we'll talk about personal sleep habits, different types of patterns of sleep that really help your patients look at to get effective sleep. So if you turn to the first slide there, it talks about the physiology of sleep. And if you're not familiar with that, one of the biggest terms is called a circadian rhythm. And when we use the term circadian rhythm, it's really looking at your 24-hour clock. So a whole 24 hours. And really, we pay attention to what we do in that 24 hours. So are we at work? Are we at school? Are we sleeping? And how much of those times a day are we doing those specific tasks, whether awake or sleeping? And so how does that affect a patient when they're in the hospital? Are things exactly the same as their schedule is at home? Well, no. And so how do those schedules change, and how does that affect their sleep? We can also factor in things like light, temperature, social activities, our work routines. All of those types of things affect our circadian rhythm and our daily sleep-wake cycles. So we all have a biological clock, and really a lot of times that synchronizes with our sleep cycles. And so again, when we're taking care of our patients, it's important to adapt our care to try to match as similar as those types of patterns that they do at home, to hopefully ensure a good night rest or sleep. A lot of times while patients are in the hospital, they are having high anxiety. They might be restless, irritable, and again, that impaired judgment might be somewhat caused by disturbances to their sleep cycle. If you turn to the next slide, it talks about the physiology of sleep. And it really looks specifically more on that slide about sleep regulation. And sleep regulation is really controlled and regulated within our central nervous system, or our CNS. There's a lot of different changes regarding our nervous system, our endocrine, cardiovascular, respiratory, muscles, all of those different things. And depending on what's going on in the body, then affects our sleep. Our major sleep center, which controls that actual sleep, is located in the hypothalamus. We do have a couple of instruments, the three of them are noted on that slide, that help us kind of monitor and figure out a person's sleep pattern. The first one is called an electrocephalogram, or an EEG is more commonly what it's known as. And it monitors the electrical activity of the brain. And you'll see they have all these different types of, I think there's a picture in your book where all these different probes are hooked up all over their scalp and their head, and it will monitor that electrical activity in the brain while they're sleeping or not sleeping. A different one is called an electromyogram. If you think of the word, or the part of the word called myo, that means muscle. So an electromyogram looks at their muscle tone. So how tense or tight are those muscles? Are the muscles able to relax during patterns of sleep? And then electrooculogram, or an EOG, really measures how many eye movements. And we'll talk about things with REM and different things on the next couple of slides. But eye movements are a good indication of what type of sleep pattern that we're in. If you turn to the next slide, it talks about the stages of an adult sleep cycle. And I'm not going to get specifically into knowing how these stages, the whole pattern, and how in depth we can look at those. A couple of the things I do want you to be aware of. The stages of an adult sleep cycle really begin at the pre kind of sleepiness, when you start to feel tired or start to feel sleepy. You might yawn. And essentially it goes into what's called non-rapid eye movement, or stage 1. And then we finally get into that actual sleep cycle. There are parts that are called non-rapid eye movement, and then also called rapid eye movement. And depending on how much of what we're in per night, depends on how much kind of restful sleep that we feel that we get. Usually a person passes through about 4 to 5 sleep cycles per night. And again, depending on what type of REM or non-REM, is dependent on, again, how refreshed they feel when they wake up in the morning. If you go to the next slide, advancing on, it talks about the functions of sleep. And sleep is, obviously, we've talked about, very important on the intro slide, especially to preserve cardiac function. The more sleep we get, sleep enhances, it reduces our heart rate, it reduces our respirations and blood pressure, it helps us to relax our muscle tone. And so during sleep, our body conserves energy, and those skeletal muscles relax. So it's that time in our time of day where our body really needs that type of rejuvenation. Sometimes you may have dreams during the middle of the night. A lot of times research tells us that when a person remembers a dream, they're actually consciously having to think about it upon awakening. But for the most part, we don't really remember the dreams that we often occur during a night's rest. Going on to the next slide, it talks and focuses a little bit on physical illness. And so when we think about physical illness, depending on what's going on, we think of the physical things that are occurring in our body. Some of them cause pain. Some of them cause discomfort, anxiety, depression, and different types of sleep disturbances. When we have those types of things occurring physically in our body, those things can lead then to things like hypertension or high blood pressure, respiratory disorders, nocturia, getting up to the bathroom during the night, pain, and things like restless leg syndrome. So where they feel their legs are very jumpy and they just can't kind of let them rest, they can sometimes be painful. So for instance, it mentioned respiratory disorders. Sometimes we use the respiratory disorder called COPD, or chronic obstructive pulmonary disease. Things like emphysema after somebody has smoked for a period or a long period of time, asthma, allergies, the common cold, all of those things can really interfere with us getting an adequate amount of sleep. If you flip to the next slide, it just gives you some common terminology that might be used in regards to sleep. And some of them we've already talked about to a certain extent. Hypersomnolence, if you think of the word hyper, means more of or increased. Somnolence means sleepiness, so hypersomnolence means excessive sleepiness. Sometimes this can be part of a diagnosis that you might take care of in a person. A polysonogram is essentially those 3 ultrasounds or tests that we talked about earlier. So it might include the EEG or the electroencephalogram, the electromyogram or the EMG, and then the electrooculography or the EOG. And so when we use those 3 in combination, It's referred to poly, meaning more than one, polysonogram. And so it's really, those tests run all together to really look at our ability to sleep or have periods of wakefulness during a nighttime of rest. Sleep hygiene, we'll talk about sleep hygiene a little bit. Sleep hygiene is the practices that a patient associates with sleep. So what do you do before you go to sleep? So do you brush your teeth? Do you wash your face? Do you go to the bathroom? Do you have this routine that you do every night or whenever you're going to go to bed? And that's really referred to sleep hygiene. So when we think about our patients in the hospital, if they're used to having a certain way of kind of prepping themselves for bed or getting ready for bed, could we emulate some of those things to kind of feel, again, more like they're in that routine? It's amazing what some of those little things can do to make them happier overall, but then also just for better care. And then again, just patterns will help them feel more like themselves. Cataplexy is really some sudden muscle weakness that occurs when people have very intense emotions going on. So they just get very weak. It can occur at a lot of different times of the day. There's not really one way that occurs. And then lastly, sleep paralysis. Some people will say that they have felt this before. I don't know if this applies to you. I can't necessarily say that I've ever felt this, but I have had students that have said they've had this. Sleep paralysis is a feeling of being unable to move or talk just before waking or falling asleep. So it's kind of like just for a few seconds where they really can't feel like they can move or they can wake up. And it doesn't last long, but it's just kind of this very quick period of time where they have that feeling. If you go on to the next slide, it talks about some of the main sleep disorders. And these are going to be important to know based fairly on terminology, but we do refer to them quite often in referring to medical terms having to do with sleep. So insomnia is really just the most common sleep disorder. Symptoms that the patient experiences is essentially they have chronic difficulty falling asleep. They can't fall asleep. They can't get to sleep, okay? They have insomnia. They just can't get to sleep. Sleep apnea is the next one. Sleep apnea is a disorder, and essentially the person that's where this is occurring, they essentially have a lack of airflow through the nose and the mouth. And so what you'll see then is when you watch them sleep or try to sleep, they'll have kind of a irregular pattern of breathing through their nose or their mouth. And then all of a sudden they'll kind of like stop for a period longer than 10 seconds. And then they'll kind of snort and sometimes then kind of take some quick breaths to kind of catch up. There are 3 types of sleep apnea that you'll want to know. The first one is called central sleep apnea. And essentially this central sleep apnea comes from the respiratory control center in the hypothalamus. And it essentially is an impulse from the brain kind of fails. And you kind of have this, again, 10-second or longer where you don't breathe. So thinking central location of the brain in the hypothalamus where that sleep center resides. The next one is called obstructive, and this is probably the by far most common one. Obstructive sleep apnea occurs when the muscles and the structure of the oral cavity and neck and throat really relax during sleep. And so essentially what the upper airway essentially becomes blocked off or partially blocked off because the airflow can't get through for greater than 30 seconds. So we'll see this a lot in the clinical setting, and that's when they'll have that breathing and they'll kind of snort sometimes and trying to get caught up with their breath. Obstructive sleep apnea has really kind of become, we've started to see it more recently in years. One of the big issues or the causes of it is obesity. People who have a larger uh, adipose tissue mass, especially in their neck, it can just be in general, puts them at an increased risk, but especially people with larger or thicker necks that have more adipose tissue, because that adipose tissue puts pressure on those areas and then cuts off that airflow. So you'll kind of see that sometimes. It also can be caused by hypertension, smoking, heart failure, diabetes, a deviated septum. So that's when their nose isn't equal and it kind of goes to one side. So only kind of one nostril is really helping them breathe. Enlarged tonsils, different kind of jaw problems. So there's a number of things. I think that the obesity is really something that we're starting to see more and more of with obstructive sleep apnea. The third one is mixed. So it's essentially just a mixture of both, signs and symptoms of both the central and the obstructive sleep apnea. When you see or hear of somebody that might potentially have obstructive or whatever type, all three types of sleep apnea, one thing that they'll most complain about is they'll complain about being constantly tired. So for them, they'll say that they got a full night's sleep, but they never feel rested. They might feel very tired during the day. You'll also hear complaints of, a lot of times, if there's like a married couple that come in together. For instance, it's maybe the husband that has the sleep apnea issue, and so the patient will complain about being tired. You'll usually hear the spouse then complain about how noisy they're snoring, that they're keeping them awake. So sometimes you kind of hear it from both sides, and then they might, sometimes the patient says, "I am not." All right. The third term down is narcolepsy. Narcolepsy is essentially just really a dysfunction of being able to regulate that sleep-wake pattern. So people will fall asleep when they don't mean to, when they shouldn't, when they're not planning on sleeping, and they have just a hard time kind of regulating that. Sleep deprivation, maybe some of you are experiencing that. I know I am right now. And sleep deprivation essentially is we don't get enough sleep, and so it causes some other issues. Some of those issues can include a fever. You can have even essentially difficulty breathing. You might have increased pain, emotional stress, medications, and what we see in the hospital is disturbances. There's a lot of people going up and down the hall, coming in and out, getting what they need from your room or from you. We have call lights and buzzers. So there's a lot of distracting things. It's not their own bed. A lot of things that cause sleep deprivation. Parasomnias are really just a couple of different terms together. So parasomnias is really a generalized term, really relating to sleep problems that happen more in children. On the actual slide, it lists some specific ones. Somnambulism is another word for sleepwalking. Night terrors, they might have nightmares. Nocturnal enuresis, so essentially bedwetting, might keep them awake at night. Body rocking, and then bruxism. Bruxism is actually grinding your teeth. So if you wake up in the morning with a really sore jaw, or sometimes you taste blood in your mouth, I do this, I've done this at different points in my life, and I'll wake up and my jaw will be really sore in the morning, or I might kind of taste blood in my mouth. That is essentially when you've been grinding your teeth during the night, and that's kind of the repercussions that you feel afterwards. As you flip to the next slide, you'll notice that it talks about sleep and rest. One thing that I think we refer to sleep and rest as the same thing, but rest doesn't necessarily imply that people are sleeping. I think when rested, or I guess I want to say rest doesn't necessarily imply either inactivity. When people feel rested, people experience feelings of you feel rejuvenated. You might feel refreshed. You might be able to carry out, whatever you need to carry out that day. Um, it doesn't necessarily say, I think it's very different than somebody, if somebody's resting, we can be resting and awake. We can be resting in a chair, or, resting, me doing something might be rest compared to me doing something else. So I think it's very different than sleep. Illnesses and unfamiliar healthcare routines, as I've just briefly mentioned, really affect our usual rest and sleep patterns of hospitalized patients. And so it's really important to allow patients period of rest, thinking about how we plan our care. Sometimes I've seen nurses where we gather all of our supplies. So what we want to do is gather all of our supplies and then go into the patient's room and get things done at one time so that they do have periods of rest in between all their different types of treatments. Everybody's coming and doing different things with them versus going in and out doing 5 different things at 5 different times. Nurses frequently care for patients who are on bed rest due to physical and psychological demands on the body. Again, just because they're on bed rest doesn't mean that they necessarily feel rested. Some people still have a lot of emotional worries that might be, it might prevent them from actually still feeling that rest and that relaxation that they really truly need. It's always important to be aware of a patient's need for rest. Lack of rest for long periods of times can cause us to be ill. Maybe you've experienced that before. Or it can actually, again, just worsen what we already have. As you flip this slide, it talks about normal sleep requirements and patterns for people at different ages. And I guess one of the things that we look at here is sleep duration and quality will differ across the lifespan. And I think if you just look in general, if we start towards the infants and the neonates, the babies, the newbies, you can see where they do spend a lot of their day sleeping. I mean, the neonate, the newborn baby, spends up to 16 hours a day out of 24 sleeping. As you see, when you go through, you'll see that that time kind of decreases as we age. So we go from 16 to 15 to 12. Preschoolers are still around 12 a night. School age is 9 to 10. And then in adolescence, we need at least 7.5. And so we hit that kind of adolescent, young adult age where we need that between 6 and 8 hours of sleep. And then it continues to decline to middle and older adulthood, where our total number of hours decline. Again, I think if we go back to the adolescence, where we really start to see they get busy with school, they might get busy with, maybe later in adolescence, jobs and different things like that. If they have shortened sleep time, it often leads to reduced performance in school, vulnerability to accidents such as car accidents, different things like that, behavior and mood problems, and sometimes, a lot of times, increased alcohol use. We see that as a factor as a result of it. As we continue to age, the more intense where we get our deeper sleep continues to decline. And so while it says the number of total hours continues to decline, I think sometimes we think of elderly people who look like they sleep all the time, but those total hours of good sleep do decline. If you flip to the next slide, it talks about factors that affect sleep. And I think this is probably one of the more important slides. There's a number of factors that affect the quality and quantity of sleep. And I think you can probably think of a lot of things even in your own life that affect that. So when we look at physical illness, high blood pressure, respiratory problems, if you've had that common cold or asthma, It's a hard time breathing at night. If you've ever had a toothache, musculoskeletal muscle pain, if you've got cramps during the middle of the night, all of those types of things, if you feel like you're going to throw up or have diarrhea, you don't get good sleep. Moving on to drugs and substances. There's a lot of drugs and substances out there. I think it's a huge problem right now. Not only with the prescribed drugs, but also drugs, street drugs, prescription drugs that are sold on the black market. And you can see some examples of there, but they all interrupt and somehow usually affect a person's sleep or can affect a person's sleep. Lifestyle, if you think about your work schedule, your school schedule, your social activities, your routines, how does that affect it? Some nights are better than others. And how does that all equal out? And how does that play a role in how much sleep you get? I think usual sleep patterns, depending on your social activities, how does that affect your sleep pattern? I think of our work schedule as nurses. One of your first jobs will most likely be or will include most likely night shifts. When you start out on the floor, I was lucky. I got a half and half job. How do you adjust to working a 12-hour night and flipping yourself around to work a 12-hour day? A day and a half later. Those things get challenges, and they really can truly have an effect on the amount of good sleep that you're able to get. Emotional stress, I think most of you have experienced that. We worry about different losses, about different stresses that might affect our sleep. The environment, if we think about our patient in the hospital, there's it's a different routine, there's different noises. If you ever go maybe a place overnight that you're not familiar with, you may have trouble sleeping because you're just not in a comfortable environment that you're used to. Exercise and fatigue can actually cause a restful sleep. So when we're tired, we're ready to sleep. Moderate exercise can also help us sleep better. So that's always a good thing to encourage to our patients if possible. Food and calorie intake, depending on the time of the day. If you've ever tried to eat like a load of food and it just sits in your stomach, you have a hard time getting to sleep. The time of day when we eat our food. Caffeine intake obviously can affect your sleep. Nicotine and alcohol are just some examples. If you flip to the next slide, it really focuses on the start of the nursing process and really gathering that assessment data. Usually patients are the best source for describing their sleep problems. And they can tell, what's changed. So, in the past 2 weeks, has your sleep cycle changed, or have you been getting less sleep, or do you feel more tired? You can ask them questions to kind of narrow that down. Their partners are also able to provide you some good information a lot of times. They might help reveal certain things that the other person doesn't even hear or understand. So again, like I referred to earlier with the sleep apneas, the person themselves may not even know that they're breathing or doing that while they're sleeping, where their partner would know that. Sometimes when we're caring for children as our patients, we do seek information from their parents or their guardians because they're usually a pretty reliable source. For instance, my daughter or my son will say that he's been up all night. Well, I know I've checked on him several times and he's been sound asleep. So again, using the parents as reliable sources in those times. The book talks about different types of scales that can help measure sleep. I'm not going to specifically go into those. I think we can just use our questioning to assess that data specifically. If the patient's sleep is adequate, again, assess for those individual things or those sleep hygiene that might help them. So, what's their usual bedtime? What's their normal bedtime ritual? What's their preferred environment for sleeping? What's their usual preferred rising time? How much sleep do they need? So, that's all included under that sleep hygiene that we talked about earlier. As you move on to the nursing diagnoses, there's some examples of nursing diagnoses for sleep disorders on this slide. Again, we've talked about some of those before, and some of them do more specifically, like the bottom two: sleep deprivation, having inadequate amount of sleep, readiness for sleep, enhanced sleep, meaning that they need more sleep, or they wish to get more sleep and maybe have just not gotten that. If you flip to the next slide, we talk about planning as part of the nursing process. Again, looking at strategies and setting our goals to help the patient figure out maybe their sleep routine, their living environment, their lifestyle, and how that affects their sleep. We might also, as part of that, have to address maybe other health problems that then thus interfere with their sleep in order to change their issues with their sleep. As you move to the next slide with implementation, there are things that are listed on the slide if we can kind of think through those things when we're thinking about helping a patient with sleep. A lot of times patients benefit most from instructions. We ask them a lot of assessment questions and then follow through, especially at their home, their lifestyle, things that promote. We're going to teach them a lot about things that promote, types of activities that promote sleep, how to make their home environment more conducive to sleep. Again, they can apply that information and hopefully that can help them. One thing to educate our patients on also is that long-term use of sleeping pills can often lead to difficulty starting and maintaining sleep. So we need to be very careful with those types of medications, whether over the counter or by prescription. As you click to the next slide too, there's a person of a nurse repositioning a patient. And I think it's really important when we think about helping our patients try to find that comfortable sleep pattern. Our sleep position, not pattern, is really important. If you ever try to, sleep in bed in a position, we have the freedom to move and the ability to move to a different position where some patients in the hospital just physically can't move by themselves. So I think sometimes it's those simple things in nursing that we sometimes tend to forget or get too busy to try to do that can make sometimes some of the biggest differences. Continuing on the next slide, it talks a little bit more about implementation in regards to specific areas where we might work. And one of the biggest things, and I've mentioned this a couple of times, but in acute care, really thinking about the environment that they're in. Patients in the acute care setting will most likely have their routine obviously disrupted. If we can control any of that type of things to control that environment, that will be helpful. Sometimes I think of things like a regular bedtime routine. So again, we talk about that sleep hygiene really prepares a person physically and mentally for sleep. That's just something that they're used to. It's part of their daily routine. The environment, maybe consider trying to make the room dark, trying to reduce the noise, trying to make the bed comfortable, good ventilation, a good temperature. Some of us like to sleep maybe in warmer conditions versus colder conditions. If we have any control of that, we want to try to look at trying to control that environment to enhance their sleeping. And again, the same thing in restorative or continuing care, making sure that their comfort, again, controlling those disturbances that might affect them with the environment. And then again, looking at that pharmacological. So what drugs, what drugs keep you up at night? What drugs might make them excessive sleepy during the daytime? And how can we maybe alter that or regulate that a little bit better? As you turn to the second to last slide here, it does mention a device that you'll see used quite often in different types of areas, but it's called a CPAP machine, or a continuous positive airway pressure machine. It's really an effective therapy. It uses nasal and it has continuous positive airway pressure. And so essentially what it's blowing air through this device whenever the patient is going to sleep. So most often at night, but even during times of naps or whatever during the day, they would want to apply this. A lot of times these are used for patients that have that sleep apnea, and the mask then delivers that oxygenated, that room air. Essentially, it just delivers air at a higher pressure so that airway can't collapse. There are different types of appliances. Some fit over their nose, some fit over their mouth and nose. But what they should do, what type of appliance they use, it should be a tight seal. You don't want that air leaking out outside of the mask. We want it all to go where it's supposed to go. And on the last slide, it's we're going to evaluate. We always evaluate as part of the nursing process. So really, have they met their goals, or has their sleep pattern improved, or has it gotten worse? So again, evaluate those measures, what we've tried, what we've been doing, what's been working, what's not been working. Again, we can use by evaluating, asking them to describe their sleep cycle, how, again, has the improvement of feeling more awake during the day, ready to sleep, have they getting better sleep, breathing, different things like that, how has that improved at night? I think a lot of times sleep really is a reflectant of a lot of other things that might be going in the body. So really our assessment skills can really hone in on maybe, once we determine some of those things, then we can focus in on those sleep areas and kind of find that happy medium to figuring them both out. Sometimes it's just whether the chicken comes before the egg or the egg comes before the chicken, if you've ever heard that saying before. Anyway, that is the sleep chapter. If you have any questions, I will be available to answer those. Have a good day.